Kady Reese is going to talk to us about the Iowa Diabetes Statewide Strategic Plan. Kady Reese serves as the program lead for Statewide Strategies with the Iowa Healthcare Collaborative. In this role, Reese helms statewide strategic operations aimed at development of cross-collaborative and multidisciplinary standards for population health to address priority health issues and disease states. She offers an array of experience across the healthcare continuum, including home health, primary and urgent care practices, healthcare administration, and quality reporting. She holds a master's degree in public health from Benedictine University. Did I say that right? Good. As well as certificates in health management and policy and health education and promotion. She is a national champion for person and family engagement with CMS as part of the Partnership for Patients and the Transforming Clinical Practices initiatives. Ms. Reese is an advocate for public and population health. Please welcome Kady Reese.
I think we've got it. Can you guys hear me well? All right, give me just a second. We talked about the fact that we're going to use the poll everywhere. So I'm going to multitask. So I've got it up here with me, so it's open. So as we go through, go ahead and text any of your questions, and we'll go through them together at the end. So I'm going to talk to you guys today about Iowa's statewide strategic plan, specifically focusing on diabetes. So today we're just going to introduce the statewide strategy. We're really going to focus on the diabetes strategy. What does it mean? Why are we talking about it? And how can it be applicable for you guys? Really looking at the intent and the purpose, and then we're actually going to go through the core components for it. So before we get started, how many of you have even heard of our diabetes statewide strategy before? Raise your hands. Okay, so about 50-50. Okay, we're good. So what is a statewide strategy? Really what the strategy document is, it is not kind of a hard line in the sand, but it is a consensus and guidance document that is outlining some of those action steps when we're sitting here together saying, all right, here's this priority issue, diabetes, that we are being faced with. What can we do? What should we be doing? And lays out those goals and tactics, not only that we can do ourselves, but acknowledging that maybe it's for our partner to do, or what are those pieces that need to be in play beforehand. And the goal of them is to advance the health and wellness of all Iowans. So it's not just about, okay, we want to get diabetes under control. But as we get into these, you will see that it's really about that whole person-centered care design and the focus on that whole person, social determinants, care coordination. Again, what is it like to live with diabetes or a chronic condition in the state of Iowa? So these statewide strategies, when we put these things out, they're not just something that was kind of developed in a bubble. It's not something the Department of Public Health or Telegen or IHC sat down and the brilliant minds that be say, okay, this is what it should be. This is what it looks like, and then everybody else can go and run and do it. It was really brought together by a multi-stakeholder group. So we had representation from hospitals, from long-term care, from local public health, from patients, from doctors, from diabetes educators, from primary prevention, really across that spectrum. We also invited the payer community, the pharmacists, community-based services such as the area agencies on aging, a variety of those components to come together to say, all right, if we're going to do this together, what would that look like? With the emphasis of improving that as the standard of care, not just something that happens once in a while, or if you live in Cedar Rapids, you get really great care, but if you are in Carroll, Iowa, it's not as great. And the idea of this is to be able to be a template for us to run through. So when we're planning programming, we're not having to recreate the wheel. We can pull from these different things to look at collaboration, but you can also do that at your local community level. So that's kind of where it comes into that two-tier application. So with these statewide strategies, they're great documents, but how many of us have seen these really great documents, sometimes that are up to 30 pages long, and they look beautiful, and they've got graphics, and they look wonderful on our shelves? How often do we go back and look at them? That was really important for us when we came together to say, these are not just documents we're putting together. It's not a check mark for a grant. It's not a checkbox for, oh my goodness, we did such great work. And then we'll come back and we'll look at it in a year or in 3 years. But there's really a statewide application. So those of us that are on there made the commitment to say, okay, we're going to take these documents and we're going to use them. And it was the Department of Public Health, IHC, a lot of state associations and agencies. Again, our payer community, the MCOs, Wellmark, we're all invited to be a part of this so that way we can collaborate and share, talk about what things really look like, what are the barriers, how can we maybe overcome them together. And to use those within our large-scale initiatives. So how can we align those resources, bring things together, and really leverage them properly? There's also local community applications. So when we designed these, we wanted to make sure that not only for us, it wasn't just for this top level application, but if you guys were to look at it yourself and say, okay, so I want to address diabetes in my community, what do I need to do? Who do I need to have at the table? What are some roles and activities that I can participate in? Have I thought of everything? Is there maybe something missing? And so some of these different areas, again, we had not just the hospital association or those big groups with us, but representation from local communities that are sharing what it looks like for them, that had the opportunity to do some buy-in. So the local state innovation model, how many of you guys have heard of the state innovation model? Okay, so that's an initiative that we have in the state of Iowa that's looking at how do we cross that sector between the traditional healthcare system and our communities and work together on that integrated system. And so within that, we have some pilot communities, and they're actually using these and testing them out. But any city, council, any government, any local hospital, a public health agency, these are applicable for you as well. And we're going to talk about our diabetes statewide strategy, but I think it's really important for us to acknowledge that we have lots of them. We have about 12 to 13 statewide strategies that are actively in play. And the reason why this is important is because we talked about those 30-page documents that never get used. These documents typically try to stay within 4, maybe 6 pages, but it's really action focused. And when we went through there, we can sometimes get really caught up in kind of boiling the ocean, making sure every single possible thing is laid out. And then that's when things get a little bit too big. So each one of these strategies builds and plays in on each other. So Dr. Mulhausen talked about social determinants of health. We cannot control and address diabetes without acknowledging those factors that are non-medical that influence ourselves and our patients and our ability to manage our own health. Now, when we go into a strategy, if we were going to dive into social determinants of health, that's its own strategy on its own. Some of those different care coordination aspects can go into those things. So as you look at these, each one of these pieces builds and plays on another. So for some stakeholder groups, when we say social determinants of health, you know what we're talking about. You kind of have an idea, you've got a plan, you know what you would be doing for those. For others, take the typical primary health clinic. Not as familiar or not sure how to address that. So these other statewide strategies come in to help fill in some of those gaps that are there. So I just want to make sure that we acknowledge that when you go through and you look at these, say, oh man, I wish this would have gone further into here or there, check out those other strategies because they offer that support. The other thing that we do is with these documents, it is to set a vision and a mission. And so we have a consistent framework that always starts with that, always keeps it at the core of what we're trying to do. So we don't get kind of lost into the details and into trying to make it focus on a program or a grant. Oh, I've got to get this activity done. If we put that in there, somebody will help me do it. So it always starts off with our mission and vision. And they're pretty much overarching, always to improve the health and outcomes for all Iowans, for everyone, not just specific populations, even though we want to make sure that we are including those high-risk priority populations in our groups. And giving ourselves a deadline, 2019, so that way, again, it's not this pie in the sky, off on the horizon type of thing, but we want to actually look at, are we improving outcomes? What about patient safety? Patient experience, which a lot of times when we talk about healthcare transformation and the total cost of care and readmissions, we lose that patient experience. And of course, we want to talk about costs. We know that's about sustainability and how we keep our services going, so we do include that as well. Again, that consistent framework typically goes on 4 different goals, keeping it concise, but we want to make sure that it's comprehensive. We look at prevention, detection, management and treatment, and data. So how can we demonstrate what we're doing and also be able to look at opportunities to continue to move resources, or maybe there were some areas we were a little bit off and we need to go back and reevaluate. But how do we make sure we know what we're trying to do is actually what's happening? So our diabetes statewide strategy. Our mission is to improve diabetes care and outcomes in Iowa, and to do that by 2019, again, looking at quality, patient safety, patient experience, and cost. And within our strategy, our whole group came together and said, all right, so if we're going to be looking at primary prevention and detection and treatment and management and data, these are those things. So we laid out our 4 goals to prevent diabetes from occurring in the first place, to ensure we detect it in its earliest stages, and when someone does develop diabetes, to make sure that they have the quality treatment and management services that they need to maintain their health and improve their wellness. And then, of course, to use that data to derive the population-based diabetes strategies. So one of the core components with this is it's not just these high-level, high-arching things. As I mentioned, this is a guidance document, but it's actually an action plan as well. So within each of these goals, we go through objectives. So objective 1 is to advance primary prevention efforts to reduce the number of Iowans who develop diabetes. Sounds like great language, right? It's beautiful. What does it mean? So within each one of these, we actually break down into tactics, and we came together and said, what would we need to do to advance that? We need to make sure that we're working together. We know we have other resources and things that are happening, so we know we have primary prevention programs. So how can we make sure people are aware of them? How can we make sure we're referring to those services? Increasing healthy behaviors in Iowans to prevent or delay the onset of diabetes. So again, looking at that prevention, that upstream focus, and this calls out some of those environmental factors. How can we support our built environment? What needs to happen to have walkable communities, to make sure that we have access to healthy foods, to make sure that people know how, when they are given fresh produce, they know what to do with it. Some of those things that, we know that for us, I know I'm gonna chop it up, I'm gonna saute it, I'm going to do that. That's not inherent for everybody. So how can we make sure those educations and supports are available for everyone? And increasing the number of Iowans who receive a pre-diabetes risk assessment. So not only within those established environments, but maybe who are some other partners that can help us do that? What about being out at health fairs and community events? Working with our businesses when they're having different types of events as they're going on, such as maybe their Christmas party, or when they go through and they have a big potluck for something. Those are different opportunities that we've laid out some structure for that. Goal 2, detect diabetes. So again, how do we educate the public on diabetes screening recommendations? So how can we make sure that when we work with our clinical partners, perhaps there's not just a poster, but they can have that as part of their education, incorporating that into wellness visits, incorporating that into even when they come in and it's for strep throat or something along those lines, but to initiate those conversations. Increasing access to quality recommended diabetes screenings and healthcare services. So some of those tactics, for example, would be to promote diabetes screening following national recommendations and tools, such as from the U.S. Prevention Task Force, the CDC, ADA. So making sure that if people are going to be doing them, they're using evidence-based materials. That folks that maybe aren't aware that they're out there don't think they have to develop it all on their own, that they're alone in this effort. And increase access to those screening opportunities through the community, the employer, again, workplace-based outlets. What can we do in our schools? What about Friday night, the local football game? What can we do there? How can we meet people where they are? And to implement those healthcare-based strategies to detect undiagnosed diabetes. So one of those ways that we can work with our clinical partners to say, okay, we're going through and we're doing a lot of population health, or you're pulling some of your folks that are on there. Is there a way that we can identify some of those folks? Maybe somebody who is, meeting those risk factors, but we haven't seen them in 6 months or a year. Can we bring them back in? Can we look at what's going on with them? How can we start looking at diabetes not just as management of those who currently have it, but getting ahead of the game? And within managing diabetes, again, we cannot, as much as we focus on prevention and we're about public health and looking in that realm, we can't forget about the folks who have diabetes. And it's not just type 2, but it's also type 1. And we want all folks that are living with diabetes to have the best quality of care and the best quality of life. So we want to make sure that our clinical systems-based healthcare strategies are implemented to improve that. So are we making sure that we're using evidence-based best practices? We were making jokes earlier about the hypertension, goals have changed on here. So is everyone aware of that? How do we make sure that our providers get that information and they're using the evidence-based best practice recommendations that are active now? They're not basing it off of what was the best practice of care in 1982. How do we go through that process with treatment algorithms and those referral processes? Increasing coordination of management and treatment activities. So again, one of those areas where if you're a primary care provider and you're treating your patient with diabetes, and perhaps there's also been a recommendation to an endocrinologist, what does that look like? Also acknowledging behavioral health components that go into that. Chronic pain management, that again, people's health does not happen just in these condition-specific buckets. So how can we make sure that everyone is working together? That also extends to those community-based services. So again, as we acknowledge social determinants of health, we look through these tactical applications. It includes that and says we have to be aware of that. We at least have to ask and know that maybe we can make a referral and let them know, have you talked to local public health? What community-based services are maybe in my area that I can connect them to? And to engage patients and families that talked about self-management. We have limited interactions with our patients and clients. And really, whether or not they improve, it happens when they're at home with their families. So do they fully understand what those activities are? We talk a lot about health literacy and things that come into play to say, all right, so we have a person who is diagnosed with diabetes, they get insulin, they go to their diabetes educator, and this is a real life example. We go through, we show them how to use their insulin, and typically we kind of use that orange to show them how to do that injection. And there was one woman, an elderly woman, who had diabetes that was just completely uncontrolled and they couldn't figure out, and she was extremely frustrated. She was doing everything right. She was checking the boxes, following her care plan, reporting everything back to them. So she came into the office and they were talking about how she was taking her insulin, and she's like, yeah, and it tastes terrible. I'm just sick of it. I'm tired of it. So when they went through and had that conversation with her, what they found out was that she was injecting her insulin into the orange, and then she was eating the orange. One of those things that even for myself as an educator, I never would have even thought in my mind to do that. And so that is really important. And that's just a story for why we have to engage in that. I mean, she had been talking with them for 6 months and they were never connecting it. They're like, she was complaining for months about citrus and why it was so expensive, and this is just getting out of hand and ridiculous. And so we thought we were just talking about her healthy eating. So we suggested she try apples and just a variety of those things. And I mean, this is a real life scenario. This really happens. And so that's why it's so important for us, especially to use Teach Back, those motivational interviewing components, even in making those shared goals. When we talk to somebody about their diabetes and we say, hey, I want your A1C at a 7, that typically means nothing to our patients. And so being able to sit down and say, you know what, though, I can work with him, and I know his goal is to walk his daughter down the aisle. He wants to be able to do that. So how can we have a shared goal and not just define it in terms that are clinical, but define it in their terms as well? That's really where we get that buy-in and how people then can invest in those activities when they're at home. And then, of course, we want to increase access to diabetes management, treatment, and support services. So those referral processes, how can we make sure that each partner is aware of what else is out there, because we are not doing this alone. We have a lot of resources that are currently here that right now we're struggling to connect with. So how can we do that better? And then how do we use that as an opportunity, especially that's kind of where we pop into goal 4, to say what's missing? Where can we better align things? Where do we need more support services? So rather than having everything localized here in Des Moines, how can we spread it out? How can we make sure that it's reaching the people who it needs to be reached? How can we make sure it's in the right setting at the right time? So again, we look at within the use of data to drive this is to increase access to diabetes management, treatment, and support services. So how do we know where they're at? How do we look at referrals, make sure people are getting there, make sure we're clearly identifying what the barrier to them going. Take our diabetes self-management education programs, for example. We may go through that process and there may be a decline in attendance, and we may assume that it's because of payment or it's because of transportation. But some of the things we've also found is that it's also a time thing for the patient to say, I don't have that much time to commit to it. I could do it online. I could do this. And so that's why when we look at some of those programs, and even with the CDC, with those evidence-based programs, they're looking at evaluating that to make sure that they're person-centered. They meet people where they're at. There is no point in having a service there if nobody accesses it. And it is not just if you build it, they will come. I think we've all figured that out, that it's not just about having it physically present. So we also want to enhance diabetes surveillance through the development of a quote-unquote Iowa suite of standardized measures. And what we mean by an Iowa suite is, so how can we pull what we know our clinicians are pulling? So we know they're looking at A1Cs, we know they're looking at foot exams and eye exams and some of those different things. But we also know our other programs are looking at things as well. So how can we pull those things in together and have a comprehensive idea of what that looks like? And put that together. And so we can use what's happening nationally, but we wanted to make sure to call it our Iowa suite because we know we're a little bit different. And that we might have access to things, and we don't want to do it just like Minnesota did it, just because of that's how they did it. We don't want to do it like Mississippi, Lord knows that. So how can we do it for Iowa? And then also, how can we use that data? So it's not just about having it, but how do we actually use that data? What do we do with it? How do we make sure we all have access and we share it? How do we make sure the public has access to it? That's a changing factor now. People are expecting now to be able to have access to that information, to make informed decisions about their healthcare. So we have hospital compare, physician compare, nursing home. We have all these things. People want to go out there and see that. So how can we make sure that it's tangible for everyone who's looking for it? And so within this execution, we talked about not just having this be a pretty document on the shelf. So we actually put some stake in the game and said, all right, guys, so we developed this plan. We're not done. We're actually going to come back together at least twice a year, and we're going to look at the current language, review it, make sure it still fits. So as we developed it, were we crazy? Were there things that we just did not understand, and now we need to update and change that? But also it's an opportunity for us to share and say what we're doing and look at those alignment and those networking components. And we do that, and we actually hold ourselves accountable through what we call a stoplight report. So we actually have to sit down and say, okay, are we red, yellow, or green? And we frequently have to challenge ourselves to say, okay, so maybe in a program or in one community, we might be green, but there are other areas but if we look at it statewide, it's more of a yellow. Or maybe it's a red. We're committed, but we really haven't made much headway on there. And so some of you guys are in the room that do these with us know I am a type A, but I also really hate being limited to those 3 colors. I like to use orange and chartreuse and all of the colors in between there, but we really like to play that in to say, okay, how do we do this? And then we come back together. So in between that time, we say, all right, we have a lot of yellows here. We have a red. What do we need to do to move that? And that's where a lot of collaboration happens in between those times. And we see that not only at the top level with our state program and our large scale initiatives, but we also see that in our communities, such as in our C3s. So what additional support can we offer to them, to our other community partners that are working through that? So just a quick little vision of what a stoplight report looks like. So you see it's by tactic. We kind of progress it out. And you see we've got some green, we've got some yellow in there. And we challenge ourselves. And we have times where something has been green and it has gone back to yellow at one point. And we had to kind of refocus. It just, cannot go out of sight, out of mind for that. The other opportunity, again, we talk about execution of the statewide strategies. A lot of us have used these strategies in a variety of different things. So for the diabetes strategy, it provided guidance and direction with our SIM. So when we were putting this together for CMS, we actually used our diabetes strategy to help develop what were we going to do? How are we going to address that again? So it's not just one of us sitting in a room thinking, oh, I think we could do this. I read about this one model this one time. But we're already using ideas and opportunities that have our multi-stakeholder buy-in. And then again, specific tactical approaches have been incorporated within the population health roadmap, C3 work plans. We've done that through the Transforming Clinical Practice Initiative. I know a lot of our other partners have done a lot of work. So Telegen also uses the diabetes statewide strategy when they're looking at the work that they're doing with clinicians, with their LAN, and with their diabetes primary prevention programs. And we connect on that to say, how can we work together? So if we've got programs here and not here, how can we leverage and turn those things around and make sure there's coverage that's there? So just a quick example here of some tactics within the roadmap just to exemplify, so it's not just bullets on a screen, and that's what Kady said, and so we're just going to trust her blindly. But there's also, again, those care coordination components, these things that factor in together. Healthcare-associated infections, again, especially with our population of people living with diabetes, that's a serious concern when something happens with wound care, a variety of those different things. If their diabetes is not controlled, it impacts the rest of their health and vice versa. So putting the tactics into action. So just a couple of examples here. So let's look at goal 1. So diabetes tactic 1-2B. So it's goal 1, objective 2, tactic B. Increase participation in diabetes primary prevention programs, including NDPP and the YMCA Diabetes Primary Prevention Program. So what are the things that we can do with that? We know work with partners to establish new programs in our community. So that's a lot of work that many of you guys have been doing. We had a question earlier about what can community-based services do? Look and see, do you have a prevention program in your community? And if not, is there an opportunity there? Could you maybe be the one that hosts that? Or do you know somebody that could be pulled in for that? Partner with our clinical providers to establish referral processes for existing programs. Our docs are anxious and they want to connect people to the right areas, but they don't always know. And one of the things I had one of my colleagues once say, for our provider community, they're so used to everything being on their shoulders. So if I'm supposed to address this, I'm supposed to create a transportation outlet, I'm supposed to be creating a prevention outlet. I don't have time, our health coach doesn't have time to sit down and talk to more patients for an hour at a time to go through this. And so if we can let them know what else is out there and that they can refer to us and what those services look like, they're happy to do so. But sometimes we have to kind of give them kind of the guidework and the framework for that. And I think we have the expertise in the room that we can do that. We also want to collaborate with local employers to discuss inclusion of DPP and their employee health programs and incentives. So a lot of times they go through, they'll do a BMI, they'll check our blood pressure, they might do some screening that's in there, but they'll do an A1C. But other than that, they don't really go through some of those different things. They don't offer an actual prevention program. They'll screen and they'll test, but there's not a lot of follow-up afterwards. So is there an opportunity for us to collaborate with them and to include those opportunities? A second example with goal 2, objective 2, tactic B, increase access to diabetes screening opportunities through community, employer, and workplace-based outlets. We hear a lot about this, and part of this is because, again, we talk about that payer community. Dr. Mohausen kind of came to it, but when it comes down to it, most of our, especially our private pay, is based off the employer. So what kind of coverage we have, our co-pays, a lot of those things come into play based off of what services they say they want to have for their employees. And so how can we work with them again and make that business case for them to say, well, if we do this, there might be an upfront cost, it might increase a little bit to offer a program, but it's actually going to save you money in the long run. It will save our staff, our employees money in the long run. So even beyond the employers, can we seek out space at farmers market, trade shows, community events? We talked about that Friday night football game. Can we be there? What can we be doing to do some of those things? The wrestling tournaments that are coming up where people are there all day long eating walking tacos. You know, where can we be present where people already are rather than expecting them to come to us? And how can we collaborate with local businesses? So it's not even through their health plan, but even working with local businesses to say, hey, if you've got a day that you're doing something, can we come and talk? Can we share something? Can we do some of these things? It doesn't have to be these formal, institutionalized efforts in order for them to be impactful. Another a tactic that we can look at is promoting referral of patients to necessary community resources to address social determinants of health. This is a huge one. Again, we've talked a little bit about this. So how can we work with community-based service partners and resources to create program links and those warm referrals and handoffs? You know, what go to your local public health or your area agency on aging has these services. Go and take advantage of them. But we never hear back on whether or not the person followed through with that, or if it supported them, or if it helped them. So how can we make sure we have that warm handoff? There's that connection between us, so that way we can share. The creation of sharing a resource list with one another. So some of us have those things. Local public health, again, I'm calling you out in the room because a lot of times we're the ones that have that. And so does somebody else have that? The local practice doesn't have that. And they're not going to keep and maintain. United Way is present, but 2-in-1 isn't the same in every community. So what are opportunities for us to connect what we have already? And again, I like to call it, this also supports care coordination tactic 1-3B. So all of these things play in together. None of these things are separate. So even though the diabetes strategy stands alone, it also comes in with everything else and acknowledges that it's part of a whole person perspective. And then reach out to your clinical partners to create those referral processes. So don't wait for them to come to you. Even if you just go in and you go up to the front desk and you say, hi, this is what I'm doing. I'd really like to work with you. Sometimes that's what it takes. Sometimes waiting to get the right contact just slows us down. So there's value in that, but don't let that be a barrier to you in making those relationships. And then of course with data. So we want to utilize diverse sources of available data, including surveillance and claims and all of those different things. So reach out and share your data. We all have access to those things. We've talked about that. Look at the things that are also publicly available that we don't always look at, such as BRFIS, county health rankings. Our provider community has no idea about those things. They are just starting to hear anything about Robert Wood Johnson for the most part in their practices, and we take some different things out to them, but they have value in that. It helps to establish the case and to build those relationships, but most importantly, talk and share. If we have data, but we always just hold on to it just for ourselves, it does nothing. It does nothing. It might help us when we put on a grant report, but it doesn't really help us advance care in Iowa. So we have to be willing to share that information. Just another example of putting tactics into action here, we look at aging, pharmacy, mental health, community planners. There's roles for every single person. The idea is that not one single organization can take this diabetes strategy and just do it on their own. None of us in this room can tackle diabetes alone. We have to work together, and there are individual pieces that are within our expertise, our resources that we can do. So what can you do? Check out the statewide strategies. Specifically, I know we've got copies of the diabetes strategy here, but look at those other ones. Look at person and family engagement. We've had a couple questions that came through on those arenas. Look at care coordination, the social determinants of health. Review those tactics and actions. Look and see where it might fit for you. Bring your stakeholders together. I don't care if it's just a simple meeting you have in the afternoon or you do a conference call, or use an existing group you already have, but bring people together to have those conversations and those discussions. And then keep watching for more opportunities to engage, because there'll be a lot more coming with this. This is just a first step. So my contact information right here, and I think we've got about a minute or so left for any questions. So I'm going to check and see if we've got any text questions that came in. The question we have here, let's see. Where is the Stocklight report available? That is currently in process to be made publicly available, so that eventually will be posted on IHC's website, and then also probably on the Department of Public Health's website, and each of our statewide stakeholder groups will be doing that. So that's, again, one of those things to watch for. We will start making those available here shortly, so having that public availability was a recent activity of ours. So let's see. what are measures by which progress towards goals are assessed? So really with this, one of the things that we do, we look at data, so we ask people to share what they have, and we try to look at those numbers. But if you look at our statewide strategy, they're not put into SMART goals with specific, we're going to increase by this amount, by that, intentionally, because we wanted to make sure that we were going across everything that we had. And so some of it is just discussion, and we have documentation of what we're doing, so that we're doing fairs. We've had more communities that are working on this. What is happening with that? And so some of it is that mix between the qualitative and the quantitative data, but we definitely look at, the NQF measures that are out there to see when we can track those things. We're looking at referrals. What's the presence of DPP programs in our self-management referral processes? So it's kind of a collaborative little mix there. And then do I have time for one more question, or should I wrap it up? Okay, let's see. And then how can the healthcare and business community better advocate for environmental changes within communities, such as better walking and biking options? So that is a key one that's in there, and I think that is the area where sometimes we leave out our community planners. We leave out some of our local businesses and our city councils and through that process, because one of the key areas that we're going through this process, we're looking at that. They have some funds, our communities are looking at that, but we have to be able to make the case, and they have to know if I'm going to spend taxpayer dollars here, it's what's wanted by the community. So one of the key things that we it took us a while to get them on there, but again, those community planners that are going through that process are key in that. So if you're looking for another partner to help kind of in that transition, that handoff, to try to say, okay, what would that look like? What would be the value and the benefit for that? They are a really great resource for you, and they are actually participating in a lot of things now to look at how they can integrate health into their community planning. So it's not just about whether it looks pretty and if the businesses are going to be there, but really looking at long-term economic vitality, which means that you have to have a healthy citizenry. So just a quick recommendation for that, but I know we're at time now, so just thanks everybody for your time.